So good morning, guys. Welcome. I'm Dr. Tan Po Tin. I'm a pediatrician. I am in my own private practice. I was with the government for 23 years. My last position was associate professor in the University of Malaysia, Sarawak. And today I have with me 5 students who has been with me for the last 6 weeks now. And today we will revise Basic Pediatrics 101. Yeah. So I hope that it will be useful for those of you who are listening to learn a little bit about pediatrics, which is always a little bit frightening for a lot of postmen and doctors. So let's go through some basic pediatrics, which will be very useful for your practice, yeah, when you go into peds wards and so on. So, okay, let me allow them to introduce themselves, starting with Magnus.
Hi everyone, my name is Magnus and I'm from Kuching Sarawak and I'm in Year 3 Monash Medicine Malaysian campus.
Hello everyone, my name is Hon Xuezi, you can just call me Hon, and I'm from Kuching Sarawak as well, and I'm also studying medicine this year, and I'm going to be a Year 3 student.
Hi everyone, my name is Ian. I'm also from Kuching. I'm also studying medicine along with these people in Monash.
Hi everyone, I'm Kuching. I'm from Kuching Sarawak also. Yeah, I'm studying medicine in Monash, Malaysia. Hi everyone, my name is Amy and I'm from Kuching as well.
Okay, so one of the first questions I ask every student who comes to me here is, how do you tell a person's age? Okay, and it may not be politically correct in medical wards, but in children's wards, it's very, very relevant. Now, let me ask Ian, why is knowing or roughly guessing the age of a patient relevant? Guessing, I'm not, so without looking at the notes, without getting the patient to tell you, just roughly looking at the patient, have a rough guess. Why is it relevant?
I think it's relevant because it allows the person who's examining the patient to roughly know how the developmental status of the child. For example, if you look at the height, we can see if the child is actually on the right developmental phase of their life.
Mm-hmm. Okay, Hon, why is it relevant?
I think it's relevant because besides what Ian has said, so when the doctor wants to determine how many dosage the drugs should be, so different height and weight has different dosage, so it should be kept in mind as well.
So yes, it's very important because when a patient, especially when you are in an emergency situation, or sometimes you're in the field, like on some trip, you know, and somebody needs medical help, it is very important to have a ballpark figure because the dosing is very important, and how you manage and what happens to the kids, it's different. Yeah? Okay. So starting from, okay, how would you roughly tell a patient's age? Do you have like a summary of how, I think Hon, because Hon has been here longer. So tell me your checklist, because in this session, we want to go through checklists that you can use at the back of your mind and that you can automatically sort of go to when you actually see a case. Yeah. So what is your checklist, please?
So first of all, when I see a children patient, I would see firstly it's the height.
Size.
The size, yes, the size. So, and also the height and the weight of the child. And then I can also see the teeth, so the teeth development can tell me roughly.
Don't go into details. Huh? So I think for this session, I want to actually help people to do portals. I call it portals. Big, see big first, starting big and then go into the smaller type later. Huh? Okay, so first of all, size. Second of all, dental development. Third of all, development milestones. Yeah. Fourth of all, puberty. Okay. So these are at least the 4 big portals. So when you look at a person's age, whatever, however they are, you look at it, you go into your portal, you say the first thing is the size. The second is the dental development. Third is dental, and then milestones, and then fourth of all, pubertal development. Okay, so these are the 4 main areas. Then you go into size. So size, you're talking about height, which you mentioned, then weight, then BMI does not help you with the aging, I mean the age yet. So the one we won't do. So height, weight, and size. Still size, okay? Size. The body build in terms of what proportions? Body proportions. Body proportions, again, very hard to say because there are some nowadays very fat people and it's tough. Okay, so no. That one will come in when you are looking at stature, looking at height. You say, oh, is this normal? This kid normal height, or is it tall kid? Is he normal, or is it just normal proportion and so on? So proportion comes in not in the age guessing, but maybe later, like BMI. Okay, what else? One more. The head circumference is sometimes actually not so useful. Again, it's one of the sub. So the 2 main ones. Okay, let's go. Height and weight. Okay. So give me your formula, Amy, for height as the child grows from 0 to whatever.
So,
50 centimeter.
and then 75 at 1, 85 at 2, which is half of the adult height, and 95 at 3, 100 at 4 to 5 years old.
Mhm. Adult height is 10 years old. 150. So repeat it for me, please, Chu.
At birth, it is around 50 cm.
Huh?
50 cm
50 cm
at birth.
at birth.
Yeah, and 1 year old is 75 cm. When they reach 2 years old, they will around 85 cm, which is half of adult height. And at 3 years old, around 95 cm. At 4 to 5 years old, around 100 cm. And 10 years old, 100 cm.
So to help our brains with remembering a lot of these things, it's all for me. I think I always use very big, big things. So I usually go 0, birth, 50, 275. Sorry, 175, 2 half adult height, 3 I don't, and then I go 5, 100, and 10, 150. In between, you can roughly work out. You can divide yourself. It's fine, But I think nobody will kill you for not giving the exact for 3 or 7. No, but the idea is half adult height, 2 years old. You see a kid walking with the parents, and they're half the adult height. You can safely say they are probably 2, maybe above. But so so I tell medical students that if you really need to know a lot of detail, exact numbers, go to Google or go to whatever, it is safer. But if you're on the just impressing your girlfriend or your mother-in-law, then maybe you just need ballpark figures, and nobody will tell you you're off. So okay. So my recipe will be 0 is at birth, Magnus.
At birth is about 50 centimeters.
50 is 1 year.
1 year is
75. 2 years.
3 years is half adult height, 85
3 years.
centimeters.
No. 5 years.
5 years is 100 centimeters.
And
10 years is 150 centimeters.
okay, so just the main ballpark figures. So interesting to note that in the first year of life, how many cm do you put on?
So in first year of life, we'll roughly put on 10.
75 minus
25 centimeters.
75 minus 50 centimeter, which is 25 centimeter. In the second year of life, from 1 to 2,
On 10 centimeters.
about 10 cm. And then after that, you put on another 50 over 5 years. Yeah. So you can see that in your mind, the first year of life, the child is growing very, very fast. That's why in malnutrition, when the child is not fed properly or not well, you can lose a lot of height growth. So, okay, so that's height. Now let's go to weight, starting with Magnus. Give me the formula for weight.
So at birth is about 3 to 3.5 kilograms, and then it doubles by 5 months.
Double at 5 months, triple at?
Triples at 1 year old.
Okay, which is?
About 10
10 kilos.
And then at 5 years old, it becomes 20 kilograms.
20?
And 10 years old, it is around 30 kilograms.
Okay, so quickly summarize without all the decoration.
Alright, so at birth it's 3 to 3.5.
3.5.
And then double the birth weight by 5 months and triple the birth weight by 1 year. So 20 kilograms at 5 years old and 30 kilograms at 10 years old.
Okay, so that's very rough ballpark figure. Yeah. So in the first year of life, how many kilograms would a child put on from birth?
So we'll put on around
They're looking for calculator.
7.
Huh?
7.
7?
Yeah.
10 minus 3.5 minus 3. That's why I like big figures. 3, 10, 3, 10, 20, 30. It's easy, right? So 3.5 is okay, but then you get stuck a bit when you minus somewhere, you know. So definitely first year of life, 7 kilo. Second year of life, third year of life, we don't know already, huh? But between fifth year is 20 and first year is 10. So 10, I also have a problem. we will edit this out. All right. So anyway, so that's useful, right? Okay. So now the teeth dental development is very useful. So Hon, I think, has been endlessly reminded. Okay, dental development. Yeah, very quick milestone. How many sets of teeth do we have?
So for children, they should have 20 teeth.
Okay.
And then the first
that is called the okay, never mind. Primary. Okay, primary. And then secondary set is
around
32. 32. So 20, 32. Okay. And the first teeth is usually appearing the lower central incisors. Yeah, at
around 6 to 8 months.
6 to 8 months. And the upper central incisors
will be 7 to 9.
7 to 9 around. And then the complete set of 20 teeth should be around
2 to 2.5 years old.
Yes, 2 to 2.5 years old. So it's very useful. The child is crying, screaming. So you quickly look at the mouth, all the teeth are there. 5, 5, 5, 5, 5, 5, 5. So that's complete 2 years at least. Okay. So the 32 teeth, when do they start coming out?
They start coming out at around 6 to 7 years old.
6 to 7 years old. So I wouldn't go into detail for that one because, yeah. So the idea is that the teeth will start dropping also around 6 to 7 years old. So when you see children smiling and their teeth have dropped off, not by trauma, but real drop, spontaneous drop, they call it, then we know that they must be at least 6 years old. Yeah. Because in our culture, perhaps if you use height and weight to guess, sometimes it's not very accurate because a lot of them are a little bit malnourished. But the dental part of it usually quite accurate. So you see anyone smiling at you, say, "Hey, uncle," and then you see the front 2 teeth, then you know they are roughly maybe 7 years old or 6 years old. So, okay. Then now the next aging, how to age is development. Okay, so development. Ian, have you read up on development? No. I think we didn't really talk much about milestone. So head circumference, I think I'd like to put it in, because I think head circumference as a measurement is very useful for children, especially in the first 2 years of life. So my recipe for the head circumference, at birth, do you know roughly what is the head circumference at birth?
35 centimeters.
35 centimeter, and then first year of life. Okay, so I have a recipe for that. Do you know? No. So first year of life, 12 cm. Just as height, the height, again, just now the height, how many cm they put on in the first year of life? 25 cm. The first year of life for the head circumference, from 35, they go up to 45, roughly. So it's 12, I put down 12 cm. Okay, 12 cm, second year of life, 2 cm. Okay. So the recipe for me, first year of life, 12 cm of head circumference, second year of life, 2 cm, and subsequently 0.5 cm, to about 7. Okay, so you can imagine first year of life, 12 cm of head circumference, which reflects the growth of the brain. So if a child has meningitis or is asphyxiated at birth, or the brain has some issues, then you find that a lot of time the head doesn't grow so well. So it's so important to protect the head growth. 12 cm of brain actually, 12 is quite a big. If you can't remember, 12 cm is half the height actually. Okay? So that's easy. So head growth is the first, I have a formula, is 63336. 633 in the first 3 months is 6 cm, and then 3 cm in the next 3 months, 3 cm in the next 6 months. Okay, 63336. So repeat after me, 6 cm first 3 months, 3 cm next 3 months, 3 cm in the last 6 months of the first year of life. Okay, so it's 12 cm first year of life, and second year of life, OMG, the head is not growing, only 2 cm, so don't worry. Okay, so then subsequently less, okay, 0.5 cm per year. So after puberty, then it should not be growing lah, even though you're a medical student and you graduate. It shouldn't grow, okay, your head. Because if the head circumference grows faster than this, it's not normal. So you need to check for something growing inside the brain. Okay. All right. Now milestones we don't have. So okay, so maybe we wouldn't go very far from there, but for roughly, so what are the milestones, the developmental milestones that you know about?
Sitting up, and then
Gross motor, fine motor, and then social, psychosocial, which includes toilet training, okay, and then speech development is very important. Speech development. Okay, we'll go on speech development because we did a lot of it. Okay, so then what else? I forgot also. In my notes. Okay, so anyway, what we'll do is we'll go to speech. Okay, we'll go to gross motor first. Gross motor. So usually the baby is like this first, and then they start sitting up. So sit up without support, usually 6 months. Okay, I'm going very big. Okay, so if you're a pediatrician, you have to go into slightly more detail and range and all that. But for general, normal doctors, enough, 6 months, sit up, okay? Some sort of sit up. And then stand up without support, with support. First of all, they will start standing around furniture. We call that cruising. They stand with support around furniture, and then they start walking around furniture, yeah? So stand up with support is 9. And then 12, usually they can roughly hands-free and try to take a few steps, okay? And then running, usually we say like around 2 years, yeah? And then after that, we'll do other things like getting them to stand on one foot, walking tandem, and so on. But that one you will learn in pediatrics. So the main thing is to remember sitting up,
About 6 months.
6 months, standing with support,
9 months.
and cruising around furniture also around 9 months, walking without support probably 12 months earlier, and then maybe slightly later, a few months later. Huh? But not to worry if you're like me, I work only at 18 months, I think. Luckily, my mother didn't bring me to the pediatrician, otherwise I'll be probably super investigated for IQ delay. No, it's gross motor. A lot of people look out for it and they think that that is a big issue. They think that the child is so good, right, that they can actually walk early. Gross motor is not well correlated with IQ. So the best correlation actually is speech development. So we learn a lot about speech development. So maybe Ian can tell me the milestone for speech development.
Okay. I think by the first year, the child should be able to produce sounds or single syllable words.
Words.
Yeah,
single words.
Yeah.
Okay.
By 2 years, I think the child will be able to speak 2-word phrases.
2-word phrases at 2.
At 3, 3-word phrases.
3-word phrases at 3.
At 4, the child should be able to speak complete sentences.
Complete sentences, but understandable to strangers. Okay.
In a single.
In one language. Okay. So as we in Malaysia, most of us speak 2 or 3 languages nicely. So so the child unfortunately sometimes get confused, so they will do a rojak, they got mixed up language. But we hope that by 4 years, every child should be able to speak clearly to a stranger in almost good sentences. Grammar is not a problem, but almost complete sentences, and be understood by another stranger. Huh? Because parents and grandmothers, they will interpret all sorts of things that the child is talking. It's actually not useful. We have to look at the way they communicate. Huh? So why is speech important, Hon?
Yes, speech is related to the child's IQ development. So if there is any speech delay, the parents and the doctor should worry about maybe the tongue development, and then the hearing development, and also there's like in the brain, so the IQ.
Okay. We'll go into that a little bit after this. But so speech development, when they first start babbling, usually the baby will babble, and suddenly they say mama or mumu or mama. You know, everybody's so happy, think that is they know. So when we say mama and point to mommy, that is correct. When they say mama to even the donkey or the dog, then it's actually babbling. Okay, babbling. So usually for 6 months or so, 6 months or so. So single words again. Emmy, sorry. Single words. 1 year. 2-word phrases. Complete sentence, strangers at 4. Okay. So it's very important for a child to be diagnosed early for any delayed speech. So Hon was trying to tell me the causes of speech delay in children. Yeah. So we didn't really go in detail about it, but I think he's trying quite well. So Ian, do you have another classification for speech delay?
I think it's very similar to Hon's one. It's either through the voicing
quality
quality
or quantity or nothing. Okay. So I'm teaching the students here usually to go from small to big, from outside in, and from top to bottom. So always have a train of thinking of progression, so that even when you are horribly nervous in front of very tough consultants, you will not lose your train of thought. Okay? So for speech, abnormal speech development, I will start with nothing. That means just babbling and completely no speech at all. To quantity, that means they speak quite nicely, words, but instead of saying 2-word phrases, they can only say single words at 2, or maybe single word at 3, which is very late. So it's too late. Okay, so but their words, when they say it, it's very clear. You can hear, you understand, it's correct. You know, dog is dog, cat is cat. But unfortunately, it's very limited in quantity. And then you have the quality issues where you can roughly, they can actually 1 or 2 word phrase, one year, 2 word phrases, 3 word phrases, but then everything is a little bit blur, you know, and then you have to check whether this is Iban or Bahasa, or which language is he speaking, or Cambodian, you know, it could be Cambodian or some language like that, so Rojak, you know. So but then if nobody understands and it's very blur, then that's where you have to worry about structural problems and so on. So your differential diagnosis will depend on quantity, quality,
and then
nothing. Quantity actually is 0 from 0. So maybe I still put it there. Put down as no speech or completely no speech development. Okay, that means babbling, and then this, yeah, and then quantity, that means they have, but it's very not according to the age progression. So, and then quality, which if you're going to speech therapy, then you'll be a different. There are so many things. So I don't want to go there because I'm not a specialist there. So now if you have a kid who is, so the differential diagnosis, yeah, for speech development delay. So if it's you can have a group. So we are talking about the mouth, the ears, and the brain. Okay. So the mouth part of it, what is in the mouth part of it?
the tongue.
The tongue, starting from the front. So again, this is an anatomical way of approaching differential diagnosis. So if you're talking about the qualitative speech developmental issues, like they sound weird, they got it, but it just sounds not clear, not well pronounced. So you start from the front, which is the lips. Okay, if you're a singer, then the lips are very important. So what could be wrong with the lips that will cause speech, abnormal speech? Yes, cleft lip, which means structural cleft lip. Yeah. Then in adults who have strokes, they have problem with speech. Suddenly they speak weird. So one of the cause is of course the brain, but the other one is the paralysis of the facial muscle. Yeah. So if they have a paralysis around the mouth or too much Botox, then the speech will go a bit weird because the lip seal and all that will be off. Yeah. So I always talk about structural. That means cleft lips, and then some problem with the lip, maybe paralysis muscle, or maybe swelling, or due to whatever, or growth or whatever, which may cause a funny sounding speech. Okay. Okay. Then you go backwards from the lip. You go backwards. You want to start at the roof, okay, of the mouth, which is palate, the hard palate, going into the soft palate. Yeah. So what could go wrong with the hard palate? Cleft palate, which can be just sometimes you can just see the soft palate being cleft. Okay. So don't just look at the hard part. You must go all the way back to the uvula. And if it's like you see the fork there, sometimes there's a soft palate cleft. Okay. Okay. Then of course, if you ask them to do and then you look at the movement of the uvula, that will give you an idea of paralysis of the muscles affecting the posterior part of the throat. Okay. So I put down structure and neurology. Usually I go structure first and then neurology. Okay. So start with ceiling, then you go down, you go to the tongue, yes, tongue, and then what else? Sometimes under the tongue there is what you call the frenulum. So a lot of people worry about short frenulum. That's affecting the way they pronounce words and all that. But And some people are very tempted to cut it, very short frenulum. Actually, we don't do it. I don't think it should be done, but I don't know. I mean, the speech therapist may have a different opinion. I don't know. But personally, we don't advise. Yeah. So tongue and then paralysis again. Okay. Paralysis of the tongue in some brain lesions. Okay. Okay. What else? Structure. Huh? Then you go backwards. Oh, then the teeth and all that is not so much affecting the speech. Yeah. Although if you have an ulcer or dental pain and all that, sometimes the speech may be weird. So, and then go backwards to the throat. What is around the back of the throat? Yeah, in front of that is the tonsils. Yeah, tonsils. So there's one condition where the tonsillar, there's a huge swelling, swelling around the tonsils, or some bleeding or some abscess behind the tonsils. They can talk weird. They talk like as if something is in the mouth all the time. Yeah. So this is quantity of speech. So when there's a quality issue or zero speech, then you worry about the brain, which is the IQ part of it. Yeah. But of course, the quality one also, you have to think about the ears. Huh? So from the throat, I usually go into the ears. So hearing impairment is very important. So when a child by 1 year plus, I think usually I like to go by 13 months. If the child is not saying single words and a lot of single words, the more the better. Yeah, the more the IQ, the higher the IQ, the more words, single words, and clear, sharp. If I don't hear that, then I always have to think. Okay, IQ, hearing, structure of the anatomy. Okay. I think yeah. So I think for medical students, I think the most important is for you guys to know some basic stuff, so that if people ask you, your future wife or your future mother-in-law ask you about the nephew or whoever who is not speaking, so you don't say like, oh, don't worry, I also spoke at 2 years old only, and now I'm a medical student, it's cannot. So definitely you have to use the milestone. Yeah? So it's useful to know. Huh? So let's go over it again. Magnus, single words.
1 year old.
Okay, double,
two-word phrases at 2 years old. 3-word phrases at 3 years old. And 4 years old is one whole sentence in one language that is understandable to strangers.
So not one whole sentence, but talk in sentence. Can hold a conversation with me. Okay, so I think I'm not including in this one the behavioral and all this psychosocial. I think it's so okay. In language development, of course, we have to put in the psychosocial, the environment and psychosocial as a course. Okay, yeah. So the psychosocial means they are brought up by some foreign maid, and then the parents don't really themselves interact with the child, and so end up sometimes the child has limited input. Huh? So or maybe an abused child or neglected child, say in a foster home or something like that, they don't speak, so and so the speech development, psychosocial development is quite important. And of course, you also watch how they speak themselves. So if the parents are speaking weird, like the pronunciation and the grammar and everything is all over the place, then of course the child may also be learning from the parents. Yeah, so you just have to play by ear. So one of the useful way we sometimes I usually use is also music. So if, for instance, the first year, 13 months or so, still no language, then I usually ask about response to music and rhythm and sound, call to voice. Of course, babies respond, turn to sound, usually. 6 months, turn to sound. So I usually ask them whether they can imitate music. So if they can listen to music and then hum it along and then dance along, then I know, okay, that means most of the hearing apparatus is still okay, not totally zero. Okay, so music is to me a useful evaluation for, if they can sing along, as they look at some of the programs. There's a lot of music and children's program right now. Any questions so far? I think anything I've missed about the Pediatric 101 that you have learned here that you think we might want to put here?
I think we have pretty much covered everything.
Yeah. So that will help you to with your pediatric posting. Yeah. I think that should be it. No? That should be it. So the details. I think you can check it out. So the idea in medicine is actually to find simple formulas that you can remember, and then always use the same approach in the same way. So whenever you look at a child now that comes into the ward, the first thing you look at is size, and then
The teeth development.
Huh?
The teeth.
The dental development, if they get them to cry, and then milestone, and then the next thing is puberty. Okay, puberty is the last one we forgot just now.